Well, welcome. Tonight we continue our series talking about some of the wonderful, actually pretty incredible services that are offered right here to Center of the Universe in Milford. We have two special guests on tonight to talk about robotic surgery, something that, I always think of Mass General, the Harvard hospitals in Boston, but we have that right here in Milford. So why don't we start with introductions?
Hi, Al. Thanks for having us here. My name is Melissa Clow. I'm a gynecologist here in Milford.
Hi, Al. Also nice to be here. Leonard DiGiovanni, also OBGYN, UMass OBGYN here in Milford as well.
Now, let's start out with, when we hear robotic surgery, visions of Lost in Space, Will Robinson robot walking up. Danger. Exactly. Yeah. Danger Will Robinson. But talk to us about what is robotic surgery?
Well, I think the vision some people have is that it can be done very remotely. That the vision was that somebody could be a soldier could be in the battlefield.
Well, wasn't that where it started? The DoD saying,
right,
"I don't have trained surgeons
perhaps
on the battlefield."
But it's not really that. It's just a state-of-the-art tool that improves your ability to do complicated endoscopic or minimally invasive procedures. It starts like a regular laparoscopy, which is a small scope placed through a keyhole type of incision in the belly button, if you will, or the umbilicus. And a case that's amenable to doing it robotically, we just hook those instruments up to the robot rather than manually manipulating them. The surgeon's console is actually in the patient room, and we're right there.
So 90% of the surgeries, or 80%, really has a trained surgeon right there using what we call the robot, the robotic arms.
100%.
Yeah, 100%.
100%. We go in with the patient. We're responsible for positioning the patient on the table and assessing the best place for the placement of the ports. And we place those ourselves. Then we connect the robot, the arms of the robot, and then we sit down at the console. We're there from start to finish. When it's all over, we disconnect the robotic arms and reverse what we started and close all the incisions. So we're there 100% of the time with our patients.
I actually had a patient ask me that the other day when consenting her for a robotic procedure. She said, "You mean you're not going to be standing right at my side?" And I said, well, actually, we are right there, right up until we break scrub and take our place at the console. And left there is our, right now, what we have in place is a second gynecologic surgeon and a physician's assistant. And we're still manipulating the instrumentation. They're exchanging instruments and devices, irrigating. So that was a concern of hers.
Well, I think it's a concern that as we see everything sent offshore, how many times you hear that the scans were read, not to pick on India or China.
Right.
Yes.
But it's a lot less expensive to do scans, electronically send them, have them interpreted overseas.
Yeah.
Well, interesting that you bring up money, because certainly if we were looking for a less expensive way to do surgery, we might not select robotics. But in this case, Milford Hospital has made a significant investment for the safety and for the benefit of our patients. So as Len mentioned, you could do telesurgery. You could sit in a room with your robotic console and operate on somebody at quite a distance in another state if somebody else had placed those trocars. We don't do that. That's not what happens with our patients, and it's not going to happen that way.
I think the outsourcing of like reading radiographs and whatnot, I don't think that we're that close to that when we talk about surgical procedures.
But I think what you hit on is something, what you said was profound. This is not about cost.
That's right.
Originally robotic surgery was about the availability of a trained surgeon on a battlefield. So that was one thing they had to deal with. But today,
it's different today. Today, it's about using technology to extend minimally invasive approaches to a much broader range of patients. So in the past, we've been able to do, for instance, a hysterectomy. That's what Dr. DiGiovanni and I do. We could do them vaginally or with a large incision across a woman's abdomen. And over time, as we developed the keyhole surgery that Len mentioned, we could do certain hysterectomies with a laparoscope with the small incisions. But those tended to be less complicated cases. There are a lot of different things that make a case complicated. It could be the size of the uterus, the scar tissue from previous surgery, the size of a patient, because a heavier patient is more difficult to operate on. And now with robotics, we're able to extend that minimally invasive approach to women who are heavier, to women with big fibroid uterus, to a woman who's had a few C-sections in the past and has scar tissue, and still able to offer them minimally invasive surgery, meaning it's fast, it's fast recovery, usually just an overnight stay, go home in the morning, less blood loss, less pain during recovery. So it's a wonderful benefit for these patients.
I mean, and cost considerations, you know, it's hard to place a value on outcomes too. There's a lot of controversy. Is there really improved outcomes? And I think the literature is starting to come through that there probably is. There's actually, you know, you can go from the president of the American College of OBGYN to going back and forth there with the president of the American Association of Gynecologic Laparoscopists, and they're at odds at whether or not they think that this should be mainstream technology or not. But suffice to say, the benefits as far as performing a major procedure like hysterectomy in a minimally invasive fashion and getting that patient home the next day and getting them back to work perhaps 2 to 4 weeks sooner, there's some cost benefits to that as well.
If you want to know about value, ask the patient.
I was going to say, let's take a step back. If somebody has to go for a hysterectomy, okay, and they come in, when would you decide to do it traditionally? You know, what would you call it, with scalpel?
Yeah.
Versus
an open procedure.
An open procedure. Because you read, I mean, obviously, a large scar across is doesn't seem to be something that anybody would want.
And even if a woman has had previous surgery, for instance, the C-section, she has that scar, that she doesn't necessarily want to use it again.
Yeah, it's hard to envision a situation where you couldn't do it robotically these days. There's very, very few.
Certain kinds of cancers.
And benign.
When would you go in a broad way and literally do an open procedure?
You know, I think we've come to the point now where Len and I would go in and place what we call a scout scope, a very small, with a single incision, a very small scope, traditional scope, and put the patient in position and make sure that we think that we can complete the case laparoscopically. Now, the positioning is a little more extreme for this kind of surgery, so sometimes a patient can't tolerate, with her heart rate, for instance, can't tolerate the positioning, and then we just can't do it. We have to flatten the table instead of tilting
it. But now, to a layman, you're taking out a uterus, and you're talking about a keyhole.
Yes.
Okay. How does it fit? I can see you going in, but how do you get the tissue out?
Well, it's got to go north or south.
Right. More toys.
So if it's small, there's a small vaginal incision, and we can deliver it.
Just take it like a baby.
Like delivering a baby, that's right. Otherwise, we have to take it out in pieces, smaller pieces.
We actually had a device called a morcellator, which we enlarge one of the incisions slightly, we place it through, and it actually removes the uterine tissue in strips, if you will. So we can take out a uterus that's
so you're just dicing it and then removing it so that you're not requiring a large opening.
Exactly.
Yeah.
I mean, cosmetically cosmetics could be a concern if it's a young woman.
Cosmetics is a huge concern, I think, in
our
field.
To all women, to most women, they care.
You know, and again, I'll never figure that out. I've been married to my best friend for 35 years, and she's still the most beautiful woman in the world. And you know, you get the but. It's like no buts. You look at, but I think it's, I guess from a guy's standpoint, it doesn't affect me, you know. I mean, I'm married to the most beautiful woman in the world. If she had a scar, okay, she's still in my eyes. But any scar, I mean, I would just think, even if you had C-sections, cutting open a scar isn't going to help the scar.
That's a large part of the post-operative pain is your incisional pain. So that's a consideration. So it's not just the cosmetics when you're talking about talking about open procedure.
The rehab. I mean, you cut through muscle, whatever. The more you
Right.
cut,
But
the
your
harder.
ability to drive, to get up and move around, to care for your family, with a large incision, we usually place restrictions for 3 weeks before you even start to drive. With this, you know.
Yeah,
it's
but
a
people
few
don't understand those
days.
larger incisions are not actually muscle cutting incisions or muscle splitting incisions. So only in extensive disease are we, cutting through muscles.
But by stripping out the tissue, if I've only got a hole yay big
Yeah.
to recoup from,
Right.
I got to imagine that the 2-3
Less
weeks got to go
pain,
down.
less scarring, less,
So far
hopefully,
we've
Just
been-
internal
moving or
scarring.
sleeping.
Right,
You know, just basic, I mean, it sounds silly, but just being able to
Yep.
sleep at night.
Yep.
that's right.
You know, how much is that worth when you say, you know, quality of life?
I tell people they're going to have incisional pain for an open procedure for 4 to 6 months. They might rub up against the counter and have incisional pain. Laparoscopic incisions, I mean, they have to hit it just right, in a few months to still have tenderness there. So there's definitely some benefit that way.
So 80%, 90% you can do with the robot?
Any case I can do open or laparoscopically, I feel I can do better robotically.
I was going to say, I have not done an open hysterectomy in a year
Yeah.
since I started
Oh,
doing,
wow.
robotics.
I had to do one on a woman with stage 4 endometriosis. So she had multiple laparotomies that I actually did her with a GYN oncologist, and it's more disease than he had even
So
anticipated.
bad scar tissue on the
Exactly.
inside.
Just no planes for dissection. But other than that, people are, we're starting to push the envelopes. And actually, that's a part of what we talked about at the steering committee last night, is how do you advance complexity of surgeries? How do you say to a surgeon, we think that case is too difficult for you to do robotically? At what point do you become proficient enough to perform that?
That's a good question.
At minimally
How do you
invasive?
become proficient? Because I read,
Yep.
and it says you have to do between 200 and 700 operations robotically to be proficient.
The learning curve is actually fairly steep, and it's different for different surgeons as well. For example, I trained in the mid to late 80s, and my mentors were wonderful about bringing laparoscopic surgery to our hospital and to our training program. And Melissa as well, were fairly skilled laparoscopic surgeons. This is just really, it starts to even the playing field. It takes surgeries that maybe would require a very technically proficient laparoscopic surgeon, and now most people can do it with the assistance of the robot. But we have gone through quite a credentialing process, and that was a big part of the 3-year journey to get us to have the Da Vinci SI at Milford Hospital. Is how are we going to credential people? Melissa took it upon herself to go out and get the training at another facility. I took a different pathway where I went through a training process
What do you
designed
train
by.
on? I mean, I see tattoo people, they get porcine bits, and
Well,
they go and train
right,
on.
And that's what we did as well.
We have a
So
yeah.
we start with some online training.
Yeah.
Okay.
And then we use a simulator, so using the same robot, but with simulation. It's an electronic simulation,
Melissa,
like
the same
playing a
as a
video
pilot
game.
Listen,
would
I
have.
could read all the golf books in the
Yeah.
world
Yeah.
till you put a club in my hand.
Yep.
But there is, in this sense, a club in your hand. So you're sitting with your Da Vinci robot and a simulator with a series of
Okay, like an airline
skill-based.
simulator.
It's very much,
Exactly.
it's patterned exactly like that. And there's a scoring system and levels of complexity to pass through. Then we do what we call a wet lab. It's a porcine lab.
Okay, so you are
We
practicing
do.
on porcine models.
Yep.
'Cause I'm trying to figure out who are you going to practice on here?
Yeah.
But you'll take
Right.
pigs and practice.
And then we observe cases. We go and watch, just stand and watch in the room, start to finish, while an experienced surgeon uses a robot. And then we do a series of cases of our own patients. And we're doing the surgery, but they're proctored. So we have a highly trained robotic surgeon that comes to be in the room with us through a series of cases. And then we graduate.
Mm-hmm.
And then from that point, most people do cases of limited complexity until they've done 1 or 2 dozen, and then as they go and gain expertise, they understand what's hard and what's not hard, to increase the complexity of the cases that they do.
Now, what I envision is that the robot is simply doing a multitude of steps. Like if you want to cut, you're moving, and the robot follows exactly what you want. This is not you programming the robot and
No.
watching it.
You're correct.
Right. You're sitting in a console, in a chair just like this, your head in a screen. You're actually immersed in the surgery. So rather than me standing at the bedside, my patient here, scrub techs, anesthesiologists, there's no distractions. You have tenfold the magnification and 3D cameras, and you're controlling every movement. So there's no delay, there's no lag between your movements. You have clutches and
If it's your third surgery, there's no hand shaking because you're tired.
It actually
That's right.
limits your tremor.
The tremor.
It
That's what I was
actually
going to
tremor
say. I mean,
reduction.
realistically,
Yeah.
I can sensitize or desensitize.
But the
The
robot doesn't do anything that we don't control.
Right.
And it's the visualization and the miniaturization of instruments that allow us to be better using a robot than we might otherwise be. But it's still inherent on our skill and understanding of the anatomy, but we can see it. As Len was saying, if we're standing here and our patient is down here for an open case, that's a longer distance. But in this case, we can zoom in right
It's
on the
also a
anatomy.
dive
comfort
in.
factor.
Pardon?
I mean, a comfort factor. When you're in scrubs
Yeah.
and you've got everybody around you, I can't imagine it's not a lot more comfortable.
We're actually operating in bare socks.
Yeah.
Yes, we are, because we're using our feet. We have foot
But I
pedals
mean,
as well.
you're comfortable.
Yes.
Yeah.
You're not sitting there with those lights beating on you, trying to make the field visual.
Mm-hmm.
It's interesting that you say comfortable, though, because it is a very immersive experience. And so, you know, when you say comfortable, it's not relaxed.
No, but what
But,
I'm thinking of is the attention. When I've
Yes.
been in surgical suites,
It's
Fully
laser
focused.
focused.
it's, I mean,
Yeah.
at least if you need to wipe your brow, or you don't need somebody else to do it
No.
because sterility is not, I mean, your aseptic technique is not being questioned
Correct.
behind a screen.
That's right.
So
But sometimes we'll just stop and say, okay, just stop and breathe, stop and exercise your fingers for a minute.
and you can
look
do that
again.
because you're not
That's right,
knee deep in the middle of
right.
the surgical suite.
Yeah. So I think from my perspective, it may advance, it may prolong surgeons' careers as well. And where maybe in your 60s you might, with their tremor reduction and fatigue factors, people can work perhaps longer.
The other thing is that straight stick laparoscopy is so linear that when we try to do difficult cases, because we want to do these cases for our patients, we move this way, we contort our bodies to try to make a nonlinear case fit the linear mold. And that translates to a lot of wear and tear orthopedically on the surgeon. And so again, that's a way in which the longevity for a surgeon may be increased.
And the fatigue factor being reduced.
Yeah,
Because
Yes.
if you're trying to get in and you say, I mean, have you ever had two cases that are exactly the same? It seems like
No.
everybody's a little bit different.
Yep.
Right.
And if you've got to be contorting yourself or your arm, I mean, the good news, Da Vinci doesn't complain. You just tell it, do this. But it doesn't get tired. And you're just human.
Yeah.
Surgeons may not believe it, but they are just plain human.
Well, you talk about safety issues and this and that. The only variable seems to be the human variable. I mean, when we go in and work, I mean, as long as you're doing everything correctly, it should be a very, very safe procedure. So the engineering is amazing. The only faulty piece of engineering is
We're back to the chair
Yeah.
to keyboard interface.
Yes, exactly.
Just like in regular computers,
Exactly.
That's
Dell
right.
will tell
Yes.
you
That's right.
80% of their technical issues,
Yeah.
chair to keyboard
Yeah,
interface.
exactly.
But now, there's procedures that always bring up emotion, especially old men. You know, when you talk about prostate cancer, you know, we had Peter Oreo on, and he was talking about one of the biggest issues is navigating within millimeters when you're doing surgery. Is the robot inherently better?
Yes.
Oh, absolutely. It's a game changer.
We have three-dimensional visualization, high definition, and 10 times magnification. So, you can take a millimeter and make it a centimeter
Yeah.
in
And we-
terms of what you
and
can see.
We have wristing of instruments. So rather than with the straight stick laparoscopy, rather than just, this is my instrument, it can only go one direction, it actually has more flexibility than the human hand, more planes of movement than the human hand. The numbers suggest that the blood loss for a robotic performed procedure is less than a similar open or
Why?
laparoscopic procedure.
Are you not nicking things, or why would the blood loss be less?
Essentially, we're using a lot of bipolar cautery. We're getting backflow bleeders. We're doing effectively microsurgery.
Well, you can see the capillaries.
Yep.
You know, when you're doing a robotic case, you're right on the anatomy and you can see. And so with gynecologic surgery, things where we might used to sweep tissue away and you'd have some blood loss that you just tolerate and work around, we just don't have it. You can see it before it happens and in a pinpoint, accurate way, stop it.
Your movements are also scaled, and we can control that scale. In other words, an inch of movement of my hand may only produce a half-inch movement in the
So you can
instrument.
customize Da Vinci to the individual surgeon.
To do
Exactly.
microsurgery.
Yeah.
Right. In the extreme for gynecology, then you might see someone do a tubal reanastomosis, so someone who's had their tubes tied and then regretted that decision can have the tubes put back together. That's very, very delicate surgery, but it can be done because everything's magnified, and then the instruments, which are micro, still are, as Len mentioned, if you can
But you
have
haven't
large
had
movement.
atrophy? I mean, if you...
Well, here's the interesting thing
if you
about
cut those
reanastomosis.
tubes, I mean, it's just
No.
interesting.
Well, there's a lot of different ways to occlude a tube, and now that you start to get into a little bit different, slightly different topic in that now with IVF cycles approaching 50% success rates, the art of reversing a tubal occlusive procedure or tubal ligation has been lost. And even when it was done frequently, it was through an open procedure very often. You'd get a lot of scarring. But effectively, let's say somebody had a ring placed on their fallopian tube or cautery applied to their fallopian tube. As long as they have a 3-4 centimeters of healthy tube there, you just remove the damaged area of tube and reconnect.
You literally cut out the cauterized area? and-
Exactly.
Yes.
Kind of like when they did intestinal sectioning?
Yeah.
Right, except they're smaller.
I was going to say,
And
except
so it's very delicate to stitch them together. The point of the example is that it's very, very small, but you can see it well enough to do it, and you can use instruments that are fine enough and still see them and control them.
so you are suturing small vessels.
With the naked eye, you could barely see the suture.
I was going to say, how do you do that?
Very carefully.
Yeah, I was going to say, can you do that by hand?
Actually,
or
I
is
don't
it-
know that there's any vascular procedures being done
Well-
as yet, but small lumens like the fallopian tube and bowel, yes.
It's amazing.
Yeah.
It is amazing.
Yeah.
It's amazing.
And now, I think the next phase that Melissa and I hope to be part of here in New England is a single site robotic surgery. So rather than 5 or
Very
4
exciting, very
keyhole
exciting.
incisions, we're talking about 1 2.5 centimeter incision.
Right at the belly button,
5
or
instruments go
maybe a little
through.
bit above, and that's it. One.
How do you get around?
That's all the engineering that goes
I mean,
into
I
it
always
by
thought
intuitive.
the idea of 5 incision points is access.
Well, the single site used to be difficult because the instruments were crossing. Now companies have come up with a way of having them come around and being elbowed and wristed so that they're not there's no collisions.
There's a small incision and a small round sort of silicone-like material is inserted there, and it has your 4 or 5 different ports, and then you slide your instruments through it, and so it's like operating with that fulcrum. And so right now the idea with single site is you wouldn't be able to do a very large uterus that way, but you might be able to do a smaller one that way. You could remove an ovary, a damaged ovary. You might be able to treat some endometriosis that way. Single incision, and then you're done. It's very exciting, and we are hoping to be one of the first sites in Massachusetts to offer that.
Is it here in Milford?
Not as yet, but I do believe that the bariatric surgery that's coming down from Worcester, I think those surgeons are going to be the first ones using the single site for gallbladders initially, and then maybe for some, what else are they going to do?
Well, I think it's FDA
otherwise.
approved for gallbladders now,
Yeah.
and so that's being done, and Dr. Cohen, who's recently joined our staff, is going to start doing those cases, I believe, beginning next week. And the gynecologic applications are expected to be approved later in the summer. And that will go out to a small number of hospitals.
Single site,
the single site, the addition of single site to what we already offer. Yeah.
Just the mere presence of of our robotic program now seems to be attracting interest from other surgeons from around the state as well.
Well, as I read through, it seems like, you think of robotic surgery, that it would be absolutely at the cutting edge, teaching hospitals, research centers. But then I read 20 to 25% of the hospitals offer some type.
Yeah, I think
That's pretty amazing.
I think when you talk about adopting new surgical techniques and instrumentation, I think there's a bell curve. I think there's the early adopters, which probably occurs at the Ivory Towers at the university,
Sure.
In the university setting. And I think we're not in the middle two quartiles, but I think we're at the early part of the slope, adopting it in a community setting.
Well, there's not a robot between Providence, Worcester, and Boston, save for ours.
Now, you want to bring in robotic surgery. You go up to Uncle Frank and Uncle Phil and say, you got a couple $1 million you're not using? I'd like to buy a new toy. Where do you start? Because these things, as you mentioned, were what, $2 million?
About fully loaded by the time you have the extra instrumentation and the maintenance agreement to go with it.
And then the maintenance is going to run you
Nice.
probably a couple hundred a year.
Yearly.
Right.
Yes,
It's always
yearly,
10.
right.
I mean, our
That's
industry
right.
says they'll pay 10%. Whatever the list price is,
That's right.
service
I
is
think that's
10%.
right.
I think it started with a urologist that we had on staff who was robotically trained and wanted to do prostates. Because that's how robotic surgery started, was 75–80% of the prostates now are currently being done robotically. So he was disappointed that we didn't have a robot. He thought for sure that we were in the process of purchasing one. I think that, if as I recall, there was some begging on Melissa and my part to have one, because we were excited about the technology and its potential.
Well, I can see bringing in prostate surgery. Because again, I mean, the whole ED issue, and when we had Peter Oreo on, yes, no man wants to talk about it. No man wants to think about it. Oh my God. But let's see, if door A is death,
Right.
I think anything behind doors B or C,
It's
Yep.
worth discussing.
yeah, I want to discuss that, because I'm not quite ready to buy that ticket behind door A. But then you hear how most of the ED issues are because they can't find the resolution,
Can't
and they're going
visualize,
to nick
right.
something.
And it's true. I think those procedures are being done better. I think there's less ED complications. I mean, the urologist can probably speak to this better, but I happen to know that the yield of lymph nodes is higher done robotically. So it seems like there's a lot of advantages to it in urologic
Well, I
surgery
mean,
as well.
the ultimate threat of either ED or thinking you got to pee
Right.
through a bag
Right.
can scare people.
Yeah.
And I would think the robotic procedure just makes me feel better that it can be more precise. I don't know if it's true.
I do think that skilled surgeons can do their open procedures with probably equal outcomes compared to robotics. And yet, I think what you'll see as a trend is that our patients from Milford were reading up, or their wives were reading up. I think what was happening a lot of times is the women would hear their husband's diagnosis and go online and start reading and go select a surgeon. And so many of our local men would go into Boston or Worcester to get their robotic surgery and lose the advantages of having care close to home.
Well, again, we joke about the little red building that was the Milford Hospital.
Yeah.
And too many of us have grown up still thinking that it's a little red, few bed building, and we had 3 doctors in town.
Right. We've come a long way.
You think about some of the original physicians who took care of you. There was no pediatrician. You took care of you from when you were born
Right.
all the way. It seemed like till you checked out. But medicine's gone so far. And now when you look at, the Dana-Farber Center,
Yes.
you look what we're doing with, Jeff Hopkins' new kingdom. The new ER.
Yeah, that's going to be beautiful.
Wow.
Yeah.
And the fact that, emotionally, not having to travel to Boston, it's quality of life. It's got to make me feel better if I have to go in for treatment.
Well, it's a lovely adjunct for Dana-Farber because now between the brachytherapy, any kind of radiation therapy, chemotherapy, and now with surgical approaches, all right here, done in concert. It's a big benefit for our patients.
Now, you mentioned, and it's great to hear a surgeon say there could be something that does it better than me. I never known we were allowed to say that. But you mentioned that technique-wise, a surgeon probably can hit the same percentage of success by hand as with the robot.
I think that's certainly true for our urologist, Dr. Sanjay Kumar. I believe that that's true. And when he was evaluating the use of the robot here at Milford, we spoke about it, and his statistics are excellent. He can do an open prostate quickly and with great accuracy. That being said, there's a desire on the part of patients, and again, patient selection being important, a role for it, and he's been a big supporter of getting robotics here for use in urology as well.
Open procedures, I mean, it's all about exposure. If you have a large incision and you have a competent or to excellent surgeon, you're going to have very good outcomes. The exposure's there. You can't. You can stay out of trouble.
When we do cell culture, we try and minimize the open area. Just the larger the area, the longer the opening. By definition, the more infections are going to, contamination is going to take over.
This is also becoming the state of practice, and in the future, as we are looking to hire new graduates from training programs, they will be trained to do procedures robotically, not necessarily in an open way.
Exactly.
I think now residents in those more advanced training programs that have robotics are clamoring for the opportunity to learn robotics, but what I've also seen is that they're duking it out for who gets to do the open case, because there aren't so many open cases anymore, and they want to have some practice doing that in their training too.
Yeah.
But now I could see, if I'm graduating, brand new surgeon, I'm going to look, if I have an option of where to go, I'm going to look at what the hospital, what the medical center offers.
You want good tools.
From a strategic
Right,
planning
absolutely.
perspective, our department happens to have 80–90% of us are mid-career. To attract those young talent, you're going to have that
It's
technology.
essential.
I was going to say, if I want to attract the top 10%, which, yes, if somebody's going to slice me open, pardon me for using such a bad term, but if you're going to open me up, I want to know that you were one of the best. Not that, okay, you couldn't find a position anywhere else, and I would think having these state-of-the-art tools will help us bring in the best people.
I think that's right.
Yep. I think we're already seeing that. Not so much in attracting, because our department just doesn't happen to grow that fast, but again, outside interest from physicians who are practicing in Cambridge and GYN oncologists and the reproductive endocrinologists from Worcester. They're all really kind of excited about potentially getting some time in the OR to work with our SI unit.
Now, it's computer-based. We've all had the blue screen of death, or the power cuts out. You read about people who are very nervous that in the middle of the procedure, you're going to have the robot, A, goes crazy, B, shuts down, or C, just stops listening to you.
We don't believe it'll go crazy. We do have, so that's part of the training is emergency undocking. How do you in an emergency situation, convert to an open procedure? And there's a couple ways to do it. It could take seconds to undock the robot and to open
Now, when I mean go crazy, if it zigs when it should have zagged, 1 in a million times, 999.99 times it's going to do the right thing. It zigged and I nicked a vein or something. What happens?
We actually haven't seen, that I know of, I haven't seen in the literature any cases of malfunction that wasn't wasn't in a response to what the surgeon was trying to accomplish. So.
We're also attentive to the details of our case. There are practices that we adopt. For instance, we always keep our instruments in our site. You don't have to, but we always do. Because if you were to notice that one moved, you'd know about it. So we keep track of the loose ends.
There are some hot spots and some risk areas of the procedure, especially it involves instrument exchanges, and as Melissa said, keeping our instrumentation in our field of view at all times. That's helpful. That's just good robotic
Just
surgery.
follow very
That's just
strict
good practice.
protocols.
But if you're in your pod, how close are you to me when I'm on the table?
About this far.
Okay, so it's not like you're sitting in
No.
India here and
Right.
it's going to take an hour for you to jump in.
We're right there.
You're right there.
And theoretically, if you had a problem with the robot itself, you've got all those little ports in place. You could undock your robot and try your hand at just a straight laparoscopy using those same ports. I expect that would be your next step before reverting to an open case.
So realistically, the step one worst case is you go back from the robotic assisted surgery to surgeon surgery.
Correct.
You're using your hands and what you've been trained to do.
An alternative set of instruments, which is what the robot is, an alternative set of instruments to do a particular procedure.
And I think that's the real key for people to understand, is that the robot is not replacing the surgeon.
That's right.
The robot is replacing a tool or a set of tools that the surgeon uses.
It's definitely a set of tools. I mean, I make an analogy to if somebody brings in a new scissor for me to use, it would take me 5 minutes to train and learn how to do that, whereas the robot maybe took 40 or 50 hours to get proficient at. So it's similar in that fashion. But the claim is that there's not a lot of downtime as far as computer-assisted movements. We haven't seen any kind of downtime. We've gone through troubleshooting drills. There's recoverable faults and non-recoverable faults. So we really, there's quite a bit goes into learning how to recover from any kind of malfunction, which in practice you just won't see.
Well, you put $2 million into any medical device, and the robot being down for a week or two, I would imagine that you'd get lots of calls from Uncle Phil or Uncle Frank saying, let's see, that's $200,000 a year to keep that thing going. Why is it sleeping for a week? But you're saying you haven't seen any real reliability issues, or
not particularly. We're on the third generation of robots now.
the SI?
Yes, the SI.
Right.
So it's I think they've got the bugs. I think it's ever improving. I think we're going to see smaller consoles. I think we're going to see improvement in instrumentation, but it's at a pretty
Well,
impressive
that's
state right
natural
now.
for any medical device. You're always going to improve to stay alive, because otherwise, Galileo is the robot. If they don't improve, there'll be somebody else. And at $2 million, there's a lot of incentive. How many people at Milford Hospital are trained to use Galileo?
Right now, there's just 7 or 8 of us.
Well, there's the 4 of us, 2 urologists and 2 gynecologists who have been doing cases. We have a cardiothoracic surgeon who is training to do cases,
Right.
Dr. Cohen from general surgery as well. And we have a few additional surgeons who have expressed interest. I think we'll
Right.
start.
So if I look at how often is the robot used, what's the use rate?
Well, we were just looking at that last night. I think that we,
Thanks to the finance department.
We're trying to figure out, scheduling's a problem because the cases can be slightly lengthier. And since we're taking our time and being as cautious as possible, there are certain things that might run faster. In other cases, we're being more cautious. So I think we're doing, how many cases a week are we doing? We seem to have about
We're doing 2 per week, and
Yeah.
he's been doing 2 per week.
Yeah.
And urology, maybe not quite so many yet, as they
But
are
if you're
working
doing
with
5 a
doctors.
week,
That's 2.5 days of surgery are being,
2.5
And then
of
with the
8-hour
addition-
days.
yes.
Right. With the addition of Dr. Cohen's general surgery, that'll be another day a week.
But you still, even when you get to 5 days a week, that's just one shift. I mean, couldn't you
Well, ORs right now generally work one shift with some extended time. I think what I predict will happen is we'll fill up the 5 days, and as people get better and our team gets more efficient, we'll be able to do 3 cases in a day instead of 2 cases in a day safely.
The OR is all about efficiencies and
Yes.
time and movement, and so we study that pretty carefully. And we have an excellent team. We have a group of people who are truly excited about being on the robotic surgery team, and so it's been a real good experience so far. And I think that'll be ever improving, but we're looking at how to really pare some of that down.
But now, once you hit your 5 days, and you go through all your efficiency, okay, so now you got your choice of second shift or Frank and Phil, we need another $2 million.
Yeah.
I think that will be Frank and Phil's decision.
Yeah.
But I mean,
rather
from
than
a surgeon's point of view, is there really a downside? I mean, do patients not respond as well if they have to go in at night, or?
Well, ideally, you like to start major cases early in the day.
Understood.
They're, nothing to eat or drink after midnight, the night before, anxiety issues, especially if you're thinking about discharging somebody day 1 post-op after a major procedure. If you finish at 11 a.m. versus 7 p.m., you're going to have a better likelihood that that patient's going to feel well enough to go
That's
home
what
the
I'm
next
asking.
day.
I mean, if I said to you, okay, tell me why I should give you $2 million and $200,000 more a year in maintenance versus why can't you do your surgeries at 8 at night?
Tired patient, tired surgeon, tired
See, that's what I'm asking.
team.
What are the
I mean,
downsides?
we do emergency surgeries at 1
Sure.
in the morning if we need to, and we manage. And yet, we're mindful of our skill and when we're freshest and best, and the safety factor for a patient. I'm not sure that patients would want to have their surgery at 8 p.m.
Well, I'd be
with
more
a
worried
tired
that,
surgeon.
it's easy to say, well, look, Len, Joe, you sleep today and work at night, but somehow patients don't seem to get the memo and only get sick when you're on call. Or not on call, but when you're on duty. So
I think
I'd be worried you're working all day, and now you're going to come in at 8 o'clock and do my surgery after working all day.
Well, fatigue, you're talking about fatigue issues as they pertain to physicians and
Sure.
residents, and I think they've looked
Well,
at
it's
it
the
in the
whole idea
airline
of the
industry.
indentured
and-
servitude.
yeah.
We put our brand new minted physicians, when you hear them working 23 hours straight.
Yeah, well, they don't
I
do
get
that so
nervous.
much anymore.
Not
Yeah, I
so
hope
much.
not.
And they'll tell us too, I'm not supposed to work more than 16 hours straight. And
But now you think about why did they do that? There was the fatigue factor.
It's safety,
Safety.
yes.
It's certainly not money, because it sounds like the robotics isn't going to really save you a lot today.
That's right.
we hope that it's a wash based on length of stays, hospital length of stays, and return to work. We hope that's a wash. But there's also some efficiencies within the case where you can minimize costs as well, as far as how many instrument exchanges you have and how many different instruments you're using.
But it's not the
'Cause those are
driving factor.
disposable.
If I come into you, the decision to robot or not to robot really has nothing to do with, well, your insurance will pay $10 for robot and $8.
We get paid the same.
Yeah.
I
either
mean,
way.
personally, you're doing surgery.
Right.
Yeah.
But
We're
from a
picking-
patient point of view,
It comes down to patient selection and risk assessment, really. You have to do the right procedure for the right person. I think as we get more experience, I think we're finding less patients, fewer patients that are actually not candidates for robotic surgery. I mean, most people are candidates for robotic procedure.
what would make somebody not a candidate? I mean, are you talking obese people that you just can't move around?
Sometimes a patient who's particularly heavy and carries their weight all in the front.
Okay, stop looking at me when you say that.
Too funny. And that can be a question of the instruments being long enough, or because many of these procedures, especially the gynecologic ones, are done with the patient tipped backward. There's a lot of pressure on their lungs and their heart, and sometimes physiologically it's not tolerable.
Comorbidity factors, heart disease.
But now how, wait a minute, Melissa, if I'm tipped back, and okay, the force vectors are this way, how does it differ robotic versus manual? I still have that weight.
Well, for an open case, you'd be flat.
Oh,
It wouldn't be as in deep a Trendelenburg, as deep till the back.
I see.
you
So if
would
I
think so.
cut you open,
So
I don't, the angle's less, so the force is
Right,
less.
that's
I think
right.
it's a little bit more difficult for anesthesia to ventilate people when they're in that deep Trendelenburg position. There's a few anesthesia concerns. I can't envision too many cases that we would do elective, which are mostly elective, where speed of the procedure is an issue, where we have to get in and out quickly. Pathology has not seemed to have limited what we can do with the robot.
Okay. So realistically, now when you say elective, most of the positions that people are in are not elective surgery. When I think of hysterectomy, it's not something you wake up and say, I don't need one, but I think I want one.
Well, many women can choose to proceed or not. If they don't have cancer and they're not hemorrhaging, then they might elect. And in fact, what I've discovered is that with the availability of robotics, I have a number of patients who are now interested in having a hysterectomy, and they would have benefited from that procedure a number of years ago, but they didn't want the big incision, and that was all I had to offer them. But now that I can use a minimally invasive approach, they're very interested.
And again,
they
it's
would
not
just suffer
just the
alone.
cosmetic, it's the whole
The
rehab.
recovery, yeah, absolutely.
Oh, I actually have regrets of some
absolutely.
cases that I'd done that I wish I had had the robot, 5 years ago.
Yeah.
No, but that's what I was getting to. You know, when you think of, oh, somebody's not going to do it because they have a big scar.
Well,
Okay,
no, it's not, yeah, it's
wait a minute.
for-
It's the 3 weeks or the 6 months of suffering
well,
thereafter.
or, you know, most women who are working, their family needs their income. They can't afford the time out of work. They may not have any disability coverage. They may be afraid of losing their job. They have young children who need care.
Well, but even if
It's a
it's
sense-
not
it's-
work, I mean, you
Yeah.
think about keeping up with your kids.
Yes,
Yeah.
absolutely.
It's a sensitive issue, much like the ED issue it is to men. The surgery on reproductive organs of women is very
emotional,
sensitive.
yes.
It's emotional. There's cultural, there's religious considerations. But the fact remains that there are some conditions that require hysterectomy, and some of them are benign, some of them are not. Most benign conditions can be really a big part of the benchmark is when somebody comes to us and say, I can't do this anymore. It's really affecting daily living.
Quality of life.
But then again, that to me affects your quality of life.
Right.
Yes.
Right.
You know, it's something that you got to deal with,
Yeah.
you know, personally, like everything else. I mean, we all make decisions that may not be what we want. I want to be young, thin, and have hair. You know, there's no chance of that anymore. So, you know, you live with what you can.
Yeah.
Are there any elective procedures being done robotically that you can think of?
Well, again, we talked a little bit about hysterectomy. Some of those are more
Yeah,
are
that's-
better indications than others.
Okay.
We're talking about treatment of robotic treatment of endometriosis. That's a pain issue. So how elective is that? That depends on your perspective, I suspect.
Right. Endometriosis won't kill you. It just
No.
makes you feel like you want
But
to
you're
die
miserable.
sometimes.
We are doing.
Yes,
yeah.
but when we say elective, it's not going to kill you if you
Right.
don't treat it. So you can elect to treat it or not. And I think this makes it more attractive to go ahead for women to
Yeah.
make that decision.
As opposed to the endometrial cancer that we would do robotically. We would do
Well,
that
again,
right. Those are
cancer to
less
me
of-
is not really an
That's not
option.
elective.
exactly.
right.
That's not
You know, you can't sit
Exactly.
there and say, unless
Right.
it's prostate that you're going to die before
Right.
it really hits you. Okay.
Or sometimes we have a pelvic mass that we just don't know if it's benign or not. We can have a high level of suspicion or high index of suspicion until the pathologist tells us otherwise. So those are non-elective.
Or conversely, we might think it's not cancer, but it's hard to reassure somebody until
Yeah, but then
You put tissue on the
psychologically, if
table.
you think you're sitting on a time bomb,
Right.
I mean, I can see it because many years ago when they found lumps, now, as a man, they just, oh, you have lumps in your breast, no problem, they're out. There wasn't even a question. But they had no idea. And the question was, well, is it or isn't it something we have to do? Well, my mind was, okay, fine, do it. You know, and luckily everything came out benign and
Yeah.
off we go. But I'd hate to be in that situation where I'd be trying to put something off because I know, and let's face it, if I need the income to support my family, You know, and especially, I mean, my darling bride's the rock of our family. You know, what wouldn't she do to feed her kids? No matter what I say, she would never listen to me anyway, but, you know, you could see her living through the pain. And if you can do something that helps her, to me, that's not really elective. You know, it's like people with migraines. You know, is it really life-threatening?
Well, many women have felt that the alternative of an open procedure was something they just couldn't do for a variety of reasons, and now they're able to better take care of themselves because
Well,
the technology favors
sometimes
it.
the cure is worse than the disease too. So there's morbidity that goes with a large or major surgery, and that can sometimes outweigh the discomfort somebody's having with a particular condition. So.
But again, when you talk about 3 days, 4 days recovery, okay, so we'll give up our vacation this week so mom can take care of herself. I can't imagine people can't do that. You talk about 6 months, you may lose your job and your ability to pay the mortgage.
After an open procedure, I would tell somebody perhaps 6 to 8 weeks out of work. I tell people it's 3 to 4 months before you go through a day that you forgot that you had surgery. Whereas with minimally invasive surgery, it's quite a bit shorter.
I think most of my patients are going back to work closer to the 4-week point, the 3 to 4, depending on the kind of work that they do. So if they're able to work from home, they might start working from home at the 2-week point. I had another patient who works in a prison, and I forbade her to go back to work until 6 to 8 weeks because my feeling was it was a safety issue. If she was thinking at all about being a little sore, that she was at risk. And her employer agreed with her. So you have to tailor again.
But again, even 3 to 4 weeks, between 2 weeks sick time,
it's short.
2 weeks vacation, you could cover it without putting your livelihood in jeopardy.
That's right.
This is fascinating. I hate to say it, but we're at the end of the show.
Where does the time go?
No kidding. we got more material too. Okay.
As you progress and we get more experience, we'd love to have you back and talk about what we're doing.
We'd love to do that.
But again, as always, take advantage. It's amazing where that little red building that we call the Little Milford Hospital has come. You know, Uncle Frank and Uncle Phil seem to be really expanding everything we do here and really bringing fantastic services that we would normally not see in a small community, albeit the center of the universe here at Milford. If you have questions, like always, call the medical center. You know, don't put off procedures because you've read that maybe it could possibly be too hard to do. Talk to the experts, let them walk you through it. And as always, to our 6 or 8 loyal viewers, thank you for watching. May God bless. And I hope that tomorrow is a healthier day for everybody than today. Thank you for coming on.
Thanks for having us.
Not too long since I've been home. Been running all my life just searching for my soul. Trying hard not to forget. Gotta go back to see what I left.